Okay, and everyone's got access to our YouTube channel, right? So we're just labeling these classes, and for those that missed, it's just EMR with the date. So if you gotta go back, watch a session because you were sick, that's what you look for. Usually record this and we start uploading it tomorrow, but it takes like 6 hours to upload these things to YouTube, so, you know, if you miss a course, I'd wait till Friday. It should be up by the following Friday, but. Okay, so what I have up here, these are Northwoods EMS District protocols. So protocols are operational and clinical guidelines for staff. So we have a chest pain that we should do A, B, C, D, E, F, G. Do we need another table? Or I should get a mezzanine for you guys. So that's what these are. And every department is different, and I'll just give an example that within the district, so we've got the ambulance service, transporting ambulance. So Northwoods is licensed as a paramedic level transport ambulance. Like Manitowish Waters now, that used to be Manitowish Waters Fire Company Ambulance, Transport Ambulance is now Manitowish Waters Fire Company Non-Transport EMR Service. So they still have a service license. And Manitowish Waters personnel have protocols, and we have protocols, and sometimes they're not the same. Like the one thing, did Winchester adopt Northwoods, or?
Not yet. We were doing our.
Which you're welcome to, or keep your own. And really they're closely aligned. So every department might have different layout, different types of protocols. And as you move forward in EMS, a lot of what we do clinically is driven off the protocol. So how I wrote ours is we have several different sections kind of based on type of response. So for example, up here, this is just our general section, and it touches on just more operational type things. So that it's not really policy, but this is things that our staff might have to bring up or recall while they're on call. Just an example, destination determination. That the state requires in an operational plan, we have to have some type of policy or protocol for how we're gonna move patients or what hospital we're going to. So this just, the protocol basically says that, pretty generic, you know, we'll provide ground transportation to patients requesting transport, obviously, for an ambulance. B, upon determination that transport will occur, our staff will provide the following options for patients. So we'll say, you know, do you want to go to Howard Young or do you want to go to Marshfield Medical Center in Minocqua? Then we have to add, in the event of local hospital unavailability, diversion, special need, or unforeseen circumstance, we may transport to these other facilities. So the one thing, like, and we're constantly reviewing these, so I'll probably adjust this a little bit, and I'll move Aspirus Ironwood up into the first option. There's some areas in our district where it's actually closer. Like if we're up on the north side of Presque Isle, that we can probably just zip over to Ironwood. But it's really patient preference that we don't dictate. It's kind of where do you want to go. For us here, literally, they're a block apart. So if you're not going to make it one block, then we've got bigger problems. But with transport, sometimes you'll hear terms like diversion, and occasionally hospitals can go on divert status. Now, it doesn't happen up here a lot, but we can have, like Howard Young can go on trauma divert, meaning trauma patients or stroke patients, don't bring them here, and we'll tell you when you can. And a lot of that has to do, has anyone ever heard of a CT scanner? So what they take imaging of your brain. These CT scanners break, or they have to do maintenance on them. So if the CT scanner goes down, they can't accept trauma patients that they might have their scan. Now we'll talk about the effects of EMTALA today, because that's in the legal, that even though they're on diversion, any high priority patient, they have to have room for that. We show up that they can. But a patient wants to go to Howard Young, they're presenting as a stroke. The and we know they need a CT scanner, we may not give them that option, that we have to take you to Marshfield Medical Center because the CT scanner's down. Does that make sense?
Yep.
So this just kind of lays it out for our staff, and as simple as it is, that's step by step by step. We have to address helicopter transport too, so I think I talked a little bit about, did I talk about the different level hospital system, level 1 through critical access? So when patients hit certain trigger points on injury patterns or assessment findings, that tells us that they probably should go to a trauma center. Our closest trauma center here is either Wausau or Marshfield. And even the trauma centers further break down that Marshfield is our closest pediatric trauma center, not Marshfield, Monaco, Marshfield. So we have a pediatric that's a trauma patient. We would request a helicopter to get them to the trauma center. And even if it's an Aspirus helicopter, they're probably gonna fly them to the Marshfield Pediatric Center if it's a pediatric. Make sense? Then again, we're not asking you to study all these, but I will come back to a few of them because I do address things like patient refusal, what to do if they're dead, those kind of things, so just guidelines. I'm just going to, let's find a normal one. So for clinical treatment, let's just take, so here's a chest pain patient. So this protocol is within the cardiac section, and it is for acute coronary syndrome / chest pain. So we have a patient that calls 911 because pain in their chest, worried they might be having a heart attack. That kind of this gives direction for staff what to do. And I don't know, how many meds do we carry? I should know this.
Lots.
Quite a few. And they all have different doses. Some go the IV, some go IM, some go orally. I don't think we have any rectal yet. Glucose remover, right. So that is a route, we will learn about that in pharmacology. Fortunately, you guys don't want to have to do that in this class, okay? I promise. We also have to state what skills they can do based on their license level. So remember we talked about scope of practice, that EMRs can do this, EMTs can do this, so on here, all levels, this means EMR through paramedic. This is our expectation. A, assess vital signs, and we'll learn what that sample OPQRST means later, of course. Administer oxygen, administer aspirin, get a 12 lead, and then sees things like if STEMI is noted, go to the STEMI, which STEMI is an actual heart attack. 8 EMTs can do IVs, get some nitrates, and then paramedics got some more stuff. So that's, when we talk about protocols, that's kind of mostly how they're laid out, or they might have algorithms, where it's a box that says, is patient talking? Yes, no. You go down, whatever. So these are, 2 o'clock in the morning, and I've been there where I'm gonna use an example of heparin, which is a medicine we can give to people with a heart condition. And we've got 2 different doses. One we give it IV, one we have to give it through an IV pump, and I get the 2 screwed up all the time. So I look at this before I put something in someone's IV, just to confirm. Okay, that's something I was gonna touch on last week. Okay. So we will jump into where we kind of left off with the medical, legal, ethical stuff, and talk about issues of patient consent and refusal. So, first off, in this country, you have a right to refuse medical care. I can show up, you can have your arm cut off, and you can say, I don't want help. And I can't force help upon you, for the most part. So, anytime we are going to touch, assess, really even talk to a patient, we need to obtain their consent, or their permission to do it. There's different types of consent that the textbook talks about. and we'll just kind of touch on. So I'm gonna start with the informed consent. And consent is just what it says, that you are giving me permission to do what I need to do. So informed consent is where I say, my name's Jason, I'm a paramedic, I would like to do an assessment on you, which would mean I need to put a stethoscope and listen to your lungs. I'm going to touch your body to see if I can elicit pain anywhere, that I'm informing you of everything I'm going to do. And then you as a patient can say, yes, you can do that. So where I get confused, how mailed someone express consent, what's the, it's where the patient expresses that they want your help.
They ask for it, right?
They ask for it. Which, a lot of times we kind of assume that by the fact a 911 call has received, which 99 times out of 100 that's the case, but every now and then we get where somebody called 911 for a patient, and the patient has no idea we got called until we walk in their house. So, you know, we come in, what's wrong? Is it okay if I do this? And they say, yeah, and we'll get going. Now, informed consent can even be broken down further, that if we're gonna do an intervention, they can consent to some things and not consent to others. An example would be starting an IV, which, again, EMRs don't have to do, but every time I have a patient and they're having chest pain, I want to start an IV to give them medicine, and I say, I'd like to start an IV, is that okay? And they may say, tell me about it, or no, I don't want that, or yeah, do whatever you gotta do. So we can't do those types of procedures until the patient gives us consent. Does that make sense? Implied consent, this is a situation I can probably best describe that if the person was appropriate, conscious talking, but we get there and they're not. So they're unconscious, they're hurt real bad, they can't talk to you, that we are implying, had they be conscious and have capacity, that they would allow us to have consent. So we get called for someone unresponsive in cardiac arrest, that we are implying they would want us to resuscitate them. Minor consent, minors really get into a different area. So anyone under the age of 18 in the state of Wisconsin is considered a minor. And a minor cannot make their own medical decisions. So if you have someone who turns 18 tomorrow and they roll their ankle at Wingman, we need to talk to a parent or guardian. Even though the person's probably, finished high school, until they're 18, they become a minor. And we kind of got a process for that of obtaining consent. Involuntary consent, when we get to these cases, law enforcement is going to be there. So involuntary consent is where law enforcement or agency has taken guardianship over a person, and basically they don't have the ability to refuse care anymore, and law enforcement or human services says we're taking this person to the hospital. There's a lot of steps that have to happen before we get to that point, and that is something that generally a law enforcement officer would be on scene. So there may be times you arrive and we just have to stand back until all this gets figured out before we can initiate treatment or care. Does that make sense? I'm going to just minimize this, so I'm going to kind of bounce back and forth.
Jason, I have a question about the minor consent,
Yes.
just because of that example with Windman. Like, I'm just curious then, what would you do in, or what if it was a, really serious injury?
So, no, that's an excellent question. I gotta get the patient refusal. So generally to give treatment, you just initiate care.
Okay.
But we're gonna do, in a week or two, we'll go over lifespan development. So how we care for a 4-year-old is different than how we would care for a 17-year-old. And a lot of it seems like common sense, but we approach littles differently than we approach adolescents and teens. So just kind of having that understanding, but if a kid's bleeding, at that point, we would imply that had their guardian been there, would want us to stop the bleeding. So it's kind of, you're working under implied consent. But in the meantime, someone else has to be working on getting in contact with the parent guardian while we're initiating care. So for us, we have a policy, or this is our protocol for patient refusal, which might help answer some of the questions. So a patient at any time has a right to refuse, which means we can be in the middle of treatment and they can say, you know what, I changed my mind. Take the IV out, I want to leave. Now, we're gonna do everything we can to talk them out of it, but at the end of the day, that patient has that right, if they have capacity. So, if I skip ahead, this is kind of one of those things I gotta bounce back and forth, but let me touch on some of the definitions. I know it's kind of hard to see. Blow up. So we use terms like AMA, against medical advice. So AMA would mean us as care providers are saying, in our best judgment, training and education, we feel you need treatment, transport, evaluation, whatever. And that person says, absolutely not, don't touch me, leave me alone. That they are going to refuse our care, that we have to have them sign a refusal, but we would document, so I'm kind of jumping ahead a couple chapters, that they are signing AMA, against our medical advice. And even if you're in a hospital, you have a right to sign out of that hospital AMA. You can literally wake up from surgery and say, get the tubes and IVs out, I'm going home. And they have to let you go, unless you're on involuntary hold from law enforcement. Capacity. This is a lot of times people get this confused with competence. So the terms get used kind of loosely, but it's really important to understand the distinction. So to determine if a person is competent, like you hear the word, are they competent to stand trial? Competency is determined by a judge, court. We don't determine competency. What we determine is if they have capacity. And capacity is a functional determination that an individual is or is not capable of making a medical decision. Now, this is a huge gray area in EMS. And this is probably one of our, it's the biggest, I guess in my opinion, patient refusal is probably our biggest risk as EMS in general. Every ambulance service administrators hate patient refusals. It just opens up risk. We're going to assess mental status, things like do they know who they are, where they are, when they are. Meaning a patient may know their name, they might know their birthday, but they don't know what year it is today. They might think it's 1974. Or they don't know their name, but they might know the date. That there's some, they have to have elements to know that they are their person of sound mind and they understand the risks associated with it. For us, a lot of times we run into that area where there may be 50% there and they have a true medical need that, look, we really need you to go to the doctor. But yet they're adamant they don't want to go, and that's a lot of times when we call in our law enforcement partners to help us make those decisions. And we've got a lot of different options, from calling the ER doc, putting them on the phone with them, calling family members. It's generally a collaborative type thing to determine capacity. Emancipated minors, you might hear this term. To be an emancipated minor in the state of Wisconsin, you have to show that you can financially care for yourself. So a kid who's 16 can become an emancipated minor, but they have to show that, hey, I can pay rent, pay utilities, and they have to do this in court. So the likelihood of us running into that, very, I know, I mean, I've got 20-year-old daughters that are struggling to meet that definition. So, you know, the person under 18, but let's say you have a 15-year-old female that's pregnant. She has certain rights with the unborn baby, but she's still considered a minor, and she's technically not emancipated just because she's pregnant. And then we also have to define the difference between patient and person. So a patient is someone who either requested help or asked someone to request help on their behalf, whereas a person is someone who had no idea. And let me describe this to you. So we get an ambulance call to the chairs outside Windman, a person's unresponsive. We drive up there, guy's slumped out on a chair, we go up, sir, he wakes up, I was just taking a nap. He didn't call 911, he didn't direct anyone to call 911. At that point, we can ask him a few questions to determine he's got capacity, and we're sorry to bother you, you have a good day. We don't need to get any information from him, he's a person, not a patient. Does that make sense?
Jason, I have a question real quick.
Yeah.
Going back to the emancipated minor, I know you said we probably won't deal with that a lot, but in the event that we do we have to see like some sort of documentation from that person? Or like how do we determine, like, yes, this kid is an emancipated minor versus their mom's just not here and doesn't wanna call?
Yeah, that's it's, if they're wanting care, it's always easy just to err on the side of providing treatment and
Okay.
help you transport. That's not an issue. It's where it becomes a real big issue is when you have, a teen claiming to be an emancipated minor that wants to sign a refusal of care.
Okay,
That's where I need to see some proof documentation. And I guess if someone goes through, I can tell you my 30-plus year career, never have I run into an emancipated minor.
okay.
Of course, you did it a few years longer than me. You ever run into one?
No.
No. We talk about it in textbooks, but
But it's just not
I've
something that comes
never
up.
run into it. Where I run into it is we have a teenager, junior high age, that 12 to 15, injured, usually a bike accident or something. We're not hurt bad. Got a rolled ankle somewhere. If it was my kid, we put an ice pack, watch him at home for a day, maybe take emergent care the next day. But there's no parents around. We can't just say, oh, you're fine, put some dirt on. We got activated, we have steps we have to take. Which I'll kind of address here. So normally, if we're going to get a refusal, so again, these are kind of guides that this is refusal of care if the patient has capacity. So this person knows who they are, when they are, where they are. That we will do a reasonable assessment that's completed and documented. So if they have an ankle injury, we're gonna look at the ankle. We're gonna make sure that there's not nerve or blood vessel damage at the injury site. And we're gonna learn about how to do that as we go through the course. Get a complete set of vital signs, so to make sure that their blood pressure isn't way off, or their heart rate's not way off. And if they still want to refuse, we have to always advise them of potential risks. So a lot of times we don't have a crystal ball. We can't see what could potentially happen. I always err on the extreme side. I'll use, we have a car accident. So if we show up, someone's standing outside the car smoking a cigarette, they're shaking them. They might have some minor cuts from glass. And I look at the steering wheel's bent, right? What usually hits the steering wheel? The chest. It's like, I'm fine, I'm just shook up. I don't want to, can we take your vital? A lot of times they'll let us check them out. For the ambulance side, it's always a lot of times, I don't want the bill. It's okay, just let us check you out. We go through everything, and at the end of the day, they're like, I don't want to go to the hospital. I have to say, well, there's potential risk that your chest hit that steering wheel very, very hard. There may be internal damage that can result in everything from heart complications up to death. Do you understand that? So, yeah, I understand. I said, okay, tell that back to me. And then I have to, document that. I told them the risk. They told it back to me that they understand what that risk is, and at the end of the day, they still have the right to refuse. And then we always have to tell them that, hey, if we pull away in 1 minute or 1 day from now, you change your mind, call us back. Call 911, we'll come, us or somebody will come get you. The next step is, okay, refusal of care, but now they don't have capacity. So think of, has anyone ever heard of the retreat bar? So we go to the retreat bar and we have a person who's hammered. They can't tell us a name. We're having a hard time, they're waking up to say, get away from me, swear at us. But they don't have capacity. So we do all those same steps, try to get vital signs and everything. But now we're having to call in jurisdictional law enforcement. That law enforcement might say, you are a danger to yourself or others, so we're gonna put you in basically a protective custody. And then either you go in the ambulance or you're going in the back of the squad car, but you're going somewhere. We may run into this too sometimes with like dementia patients. So persons at home where we see it a lot where I came from in like nursing home or CBRF settings, but up here it may be, I'm just gonna say Mrs. Smith has bad dementia. And she had fallen, husband wants her checked out, husband's primary caregiver, family members are there, and she doesn't want to go to the hospital. So we can encourage them as much as we can, but if a family member says, we have medical guardianship, which means we can make the medical decisions, at that point we can transport the patient against their will because the guardian is telling us. Which, and again, I'm kind of going over a little bit because at the EMR level, you guys are just showing up and assessing and providing treatment. There's really not that legal risk for you. But because you may be part of an ambulance crew, these are things that we have to touch on and talk about. With the minor, we've basically all the kind of same steps, except we got to try to get a hold of the parent guardian. There is some exceptions that we are able to do this via phone if we have to. I don't like doing it, but I can talk to mom or grandma via telephone. Just say, hey, Bobby rolled his ankle, it's swollen, probably needs some medical attention, he's talking, he's alert. We are always going to encourage that he seeks medical care, and we're happy to do that. But the family member can make that decision. If we cannot get a hold of a family member, we revert to calling law enforcement. So anytime there's a possibility we have to move a patient or a person against their will, we want law enforcement there. Does that kind of help clarify that a little bit? So just kind of a lot of busy steps, and then we've always got the documentation, which we'll get into tonight, that we just write this stuff down, kind of word for word, use quotation marks. End-of-life directives, and a lot of this is with do not resuscitate orders. So I believe I touched on this already with you guys in the last week or two, but a do not resuscitate is a relationship between a person and their primary care physician. The physician is the one who has to, I guess, authorize, if you will, a valid do not resuscitate order. There was a period, I don't know, probably, I'll look at Steve, our paramedic today, because you still run Lifestar once in a while.
I do.
And run some nursing homes and CBRF, so.
I do.
You went into kind of the advanced directives where if they deteriorate, you can do these things, but not these things.
Like a DNI instead of a DNR,
Yeah.
stuff like that, yeah. And honestly, what I default to is I call the emergency room. I said, well, where is your paperwork filed at? If they don't have it, if they're not sure, and they're like, hey, I do have this, but I don't have it here, or this patient just want to be intubated, but they want the compressions, something like that, I'll call the ER and I'll just talk to the doctor. I'm like, hey, what do you guys have on file? And then I'll obviously get their name, just like we'll give you a medical direction or whatever.
So I do want to start and just make you comfortable with this, that if you show up to someone who's collapsed in a cardiac arrest and you initiate CPR, and we find out that they're a do not resuscitate, you're not in trouble. That you will never get in trouble for attempting resuscitation on someone that turns out to be a do not resuscitate. Where we can get in trouble is if we respond to a cardiac arrest and we don't do CPR because someone told us they were a DNR when they weren't. Does that make sense? You know, grandma's got a lot of money and the son's there saying, yeah, guys, don't do nothing. Let's just get this over. You know, does that happen? I don't know. I probably see it, but you gotta be careful with it. But the do not resuscitate, they're either going to have an identification. It's either gonna be a jewelry of some type, a necklace or a bracelet, or like a hospital band bracelet. So in Wisconsin, a do not resuscitate, medical alert, like if you've ever heard of medical alert bracelets, and we'll learn about this in assessment. So, you know, if we're doing cardiac arrest, CPR, and, you know, we start CPR and then we remove the shirt and we see the pendant there that says do not resuscitate, and we can stop at that point. But the medical alert bracelets have to say, state of Wisconsin, do not resuscitate. Where we might run into some issues up here is there's a lot of non-Wisconsin residents. I'm not really sure what the Illinois law is for them. The hospital band looks just like a hospital band, except it will have a imprint of the state of Wisconsin seal on it, and it will say do not resuscitate, physician, so and so. When you arrive to someone, and do not resuscitate is essentially saying we don't do invasive type things. We don't put breathing tubes in, we don't do chest compressions, that if we find them without a heartbeat or not breathing, we don't provide intervention. Do not resuscitate does not mean do not treat. So someone with a DNR breaks their arm, we can still splint their arm, give them pain control, and transport them to a hospital. We're just not doing chest compressions and mouth and all that stuff. A person that has a do not resuscitate, they also have the right to revoke that at any time. So literally in their last breath, they can say, save me. At that point, you direct a family member or you remove that bracelet and you resuscitate. I've never had that happen. What I have had happen is when we show up to a house and they don't have a do not resuscitate order and your family says, please don't start. Now we're in a tough situation. So what I would advise with EMRs is that you communicate with the incoming ambulance that we have a cardiac arrest. The family is requesting we do not start anything. What do you want us to do? Now, if I'm coming, what I would say is try to talk to the family and just tell them that if we need to start this, and when the ambulance gets here, they can figure that out from there. Because we're gonna do a couple things. We're gonna call the ER doc. Generally, if the scene is safe, we will start BLS, chest compressions, immediately call the hospital. And that's kind of what our or guidelines suggest. One time in my career, I did have family members become threatening and violent. And their father had severe dementia. They never went through getting the do not resuscitate paperwork. And the son actually grabbed a piece of lumber and said, I'm gonna start beating you with this if you do one more chest compression. Well, at that point, the scene becomes unsafe. So what do? I say, oh, okay, we'll just back up, you know, and get me law enforcement quickly. But, yeah, we just kind of take those, but I've also had them where, hey, look, we need to confirm this, but until we confirm it, we need to start. We're just gonna start some CPR and we'll get the ball moving in to get there. We're gonna call the doc, and once the doc says stop, we can stop. But if you're in that situation, you explain that. If the family's adamant, no, you don't. It's not worth you being assaulted by a family member. Does that make sense?
I'm just curious how you would get called in the first place,
Yeah.
like maybe the patient.
They get scared. Almost every time, and even when they do not resuscitates, you know, they know their loved one is terminal. They know they're going to die, and then they actually die. And it's, oh my God, what do we do? Or, I've seen a lot of times they'll call 911 after they're dead. Because they, you know, what, they don't hand books out to this in school that, hey, someday, when you're in a room and somebody dies, and we know they're going to die, what do you do? So they call 911, because they're not sure. Well, 911, they wanna make sure that, hey, they don't put themselves at legal risk, so they're gonna send everybody. The family may say, hey, Dad's here, Dad's got terminal cancer, he just took his last breath, so we're calling you to notify you. And dispatchers say, we gotta send everybody. You know, are they under hospice care? And if there's not under hospice care, that they're gonna, you know, they'll page us, hey, got a cardiac arrest, no one's starting CPR, and then we gotta get them.
Who are you supposed to call?
Hmm?
Who are you supposed to call in that situation?
Well, you do have to,
If someone's
well,
just dead?
so if they're under hospice care, or palliative care, you call the hospice nurse.
Okay.
She takes care of her, he takes care of everything. You know, they may say, I'll be there in 4 or 5 hours. So you may have, you know, a deceased family member in the house for several hours before someone gets there. And then the nurse has to come, do what they do, and then they call funeral home, and every area is a little bit different. That's not a reportable death to like a coroner medical examiner in hospice. Hospice patients are typically do not resuscitate, but not always. So you can be in hospice and still be a full resuscitation. Very rare, but I have seen it a couple of times. When they're not in hospice, and there's a lot of families that believe that we take care of our family. And we don't need a hospice, that, you know, Dad's dying, we're gonna be here with them, be family, and when they die, who else they need to report that we have a dead person in the house. And even if they call the funeral home, hey, Dad's dead, come get him. The funeral home's gonna say, you know, they just can't come and take a body without it being reported to law enforcement. So that's where a lot of times you get this, everyone shows up, and we don't do much. That's it. And again, what we're talking about today is a lot of gray area. Just fortunately, as the EMR level, you show up and they're like, don't do nothing. You don't. You would never be legally culpable in that case for not providing care. Does that make sense? A lot of kind of question what, so I mean, this time, I mean, open discussion. So if anyone has more questions about it.
Yeah, I have a question. I've arrived on seeing the opposite quite a few times, where there is a DNR, and then the family says, I want you to do compressions, and one went as far as to say, she said she didn't want to die, she wanted help, as we watched her die. That's kind of what, we don't call medical control for that, but in that situation, what, is the DNR the trump? Or is her word of the patient saying, I don't want to die, trump the DNR?
I've done that a lot, and we have 2 options. So legally, we are, if the family says, the patient said they wanted to be saved, then you gotta tell them, you need to remove that bracelet, and we're gonna do our thing.
The family would remove the bracelet.
Technically. Or someone needs to take it off. Otherwise, in other instances where, and I'll kind of paint a picture, and again, I'm not trying to make light, I mean, this, death happens, okay? It's inevitable for all of us in this room. You know me and my cheery talks. Hopefully not for a very, very long time. But we've responded to calls, and I use this example where you walk in a living room and they have a hospital bed in the living room. So this person's pretty much like their quality of life. And I hate to use quality because I don't know what their quality was, but they're limited in their daily activities. So we arrive, we see a very elderly person, emaciated. So no protein, I mean, they're malnourished. And again, not abuse malnourished, but just their body's not absorbing calories anymore. They're shutting down. And so they're rail thin, there's nothing left of them, they're in a diaper, and the family says, you know, we want you to do everything. We know as EMS that we can't fix this. the hospital can't fix this. But family's there, the emotions are up, we say, okay, give them a cot, we initiate resuscitation, we get an ambulance, we call the ER that, hey, this is what's going on, and 99% of the time, the ER physician would say, just please stop resuscitating this baby here. Now, under other normal circumstances with ALS now, especially, and some BLS systems can do this, but we can terminate resuscitation on scene. So we can be in a living room, manage a cardiac arrest, and at some point, we determine nothing's getting better, so we call the ER physician and basically we stop termination. At that point, it begins to shift. We're there to support friends, family, survivors, and help prepare them for the next steps. And I believe up here, and I haven't got, the next step is a medical examiner comes to the scene. Those I've been doing it. So, and the ME up here, don't they service 3 counties? So that very well may be a while for them to get here. Doesn't mean you need to stay there. But someone needs to stay and preserve the scene, which is typically law enforcement's job. So like I would expect my ambulance crew, that once law enforcement can assume control of the scene, to be there, that the ambulance crew is gonna, once we determine the families kind of got the support that they need, the ambulance crew is gonna clear be available from law enforcement stays until the ME gets there. And then I don't know if the ME transports or if the FEMA transports. ME does? You got a hitch hauler or?
I got a van.
I just called the funeral home. I wasn't gonna put them in my car. Did that answer, yeah, so usually up here and I know we kind of beat that to death, but DNR is, I would say it's more likely that when they are DNR and we get called that we walk in the door and, the family says, hey, we got scared, but they have a DNR. Okay, collect information and leave. This textbook must have been in Ohio. Talk about refusal capacity. I told you I was going to kind of do this. Negligence. Negligence gets talked about in every level of EMT class. Guess how do I? Has everyone heard the term like negligent behavior? So, and there's different types of negligence, and I don't know if this gets into. Okay. So, negligence is a law in which there was no intent to do harm, if there was a breach of duty to act. Patient had harm. So I'll kind of break down these 4 elements of negligence, and if there's ever a quiz or you guys take registry, this is probably going to be on it. The 4 points that have to be proven for negligence. So number 1, there was a duty to act, meaning for like an ambulance provider, Steve and Renee are on shift right now, and if someone in Winchester collapses, they get paged all day with a duty to act. Now, if you are an EMR volunteer and you're not signed up for call, your radio goes off, you don't have to go. You're not bound to, you don't have that duty. But if you're on call, you respond, that was we breach that duty. Now, there's a lot of ways we can breach that duty. We'll kind of talk about abandonment or that we don't respond. The person suffered harm because of that, or, we breached negligence by we did something outside of our scope of practice. I use that extreme example, like we try to do a surgical airway on someone. Again, we're not going to teach that in schools. But that's a breach of our duty. The patient suffered harm, and the injury was a result of that. So we did something inappropriate and the patient got hurt because of our actions. That is negligence. I'll finish this up. So you guys aren't really good at saying, hey, it's a great event. We don't need that. I'll just kind of touch on these few things here quick, and then we'll take a quick break. So, abandonment is where we initiate care for treatment of someone, and then we leave, we abandon. There are times when abandonment will and should occur. When abandonment will and should occur, that would be we initiate care on someone who seems rapidly becomes unsafe. Okay? That's not abandonment, that's you protecting yourself. Okay? We just say, we're out of here. Okay? And that's, but if we did that, if we started care on someone and the ambulance is 10 minutes out, but the Packers start in 3 minutes, so we say, hey, you're good, I put a bandage on, you'll be good, the ambulance is coming, and leave that to me. The other case would be like in a mass casualty incident. And we're gonna learn something called triage, where we're spending about 30 seconds. So we have a school bus rollover. We have 15 people in that school bus, and we have to spend about 30 seconds to a minute with this person, 30 seconds to a minute with this person, so we are moving patient to patient. That's not abandonment, that's triage. Assault and battery, this is where this kind of ties in with that consent. So assault is verbal. So if I just like yell at you and, hey, calm down or I'm gonna beat your ass, that's assault. And if I say, come on, we are going to the hospital, that's battery. It doesn't mean I have to hit him, it's just I'm touching him unwanted. False imprisonment, this is someone that has capacity, that we didn't go through the proper steps, and we just pick them up, we log time, put them on a cot, take them to the hospital. That's kidnapping, false imprisonment. And then EMS defamation, where that kind of sneaks in, is that we are, especially with documentation or violation of confidentiality. So defamation is spoken. So I'm at say I'm talking to a friend that, yeah, we had a car accident yesterday. I could smell that guy was drunk, definitely drunk. And it gets back to that person, and he said, no, I wasn't drinking at all. But that's defamation. Right? Slander or libel would be, I write in my report, patient was drunk, and I have no evidence to prove it. Now, we go to a car accident, I'm not sure. What's not libel is I can say, there was an odor of intoxicants on the scene. I could smell alcohol. I don't know who it could have been the patient, could have been my partner. I could smell odor of intoxicants. Yeah, that's factual. That's not libel. Does that make? Okay. All right. Let's take a quick break.
Remember to pause the video.
Thank you. That's the right one. Here's how it typically happens. If someday we go on an ambulance call today, and it's gonna end up in court. I'm gonna say even criminal or civil. So criminal would be, we were on an ambulance call of a shooting, or person A attacked person B, resulted in it. That's criminal, right? Someone physically hurt another person. Or there's civil action where a person broke their neck and the ambulance never put a seat collar on, or something like that. They can take civil action against your ambulance. Or you get pulled into potentially a courtroom, not because you did anything wrong, but because you're testifying on behalf of either the defendant or the plaintiff. So, what I was getting, accident happens today, we usually don't see a courtroom for a couple of years. So, even here with the low call volume, I don't remember a call I was on last month, let alone 3 years ago. So in that time, when I get that piece of paper that says you are summoned to appear in court, I need to go back and look at my report to understand. So if I didn't write it down and write it down correctly, you know, I'm going off of what I wrote. I might remember some things, but that's why the documentation is so important, because in the rare case that you get called to testify on it, it's not fresh. It's from a long time ago. Don't be intimidated by it, and like I can speak, if you're ever within the district or you're responding as part of an agency, that number one, you get a hold of that agency and they're gonna get their lawyer involved. Okay, this isn't something you need to get your own lawyer necessarily if you're just getting called in. So I've been called in on a lot of, I shouldn't say a lot, probably in my career like 6 times. And it was never, you know, that I wasn't in the suit or my agency, that we did something wrong. It was, we were being called in to testify for the prosecutor. This is what we saw. You know, I observed as I pulled up, 2 people ran away, those kind of things. Probably twice as much as a coroner, which is even, you know, that's even 2-3 years after. So like my coroner report is 2-3 pages long, that as I'm in the courtroom, I'm literally reading what I wrote, which the courtroom could have done without me there. I get to give up a day sitting in a courtroom. Anyways, it's nothing to be intimidated that if and when that day would ever come, you just get a hold of that ambulance provider and they're gonna help you navigate. It's not, just because you get called, it doesn't mean you're in trouble. It's kind of what I'm saying. Just work within your scope of practice, provide the best care to your ability, and you're fine. And then just document it.
I'm just curious on a practical level, like, do you mostly just remember what happened and then once you drop the patient off at the hospital, you write down what happened? Or
Yes.
are you kind of keeping track of times and writing down some notes as you go?
Yeah, and I'm gonna, you know, we'll get into that tonight, the whole documentation thing. And I'm gonna pass around this too. So what I'm passing around here is a patient care worksheet. So we are required by, can't remember the statute or rule, we have to leave some type of documentation with the patient at the hospital. So I drop the patient off, I have to say, here. And you guys can take these are just, every department, we're just using the generic state of the Wisconsin one. Just take one, pass it around. And same thing, there's no information on there, so you can throw up the garbage. It doesn't care, but that's our kind of scratch sheet. So typically what I would do, write that stuff while I'm on scene. We have a tablet where we document, and I'll kind of show you a program we use. A lot of it's kind of drop-down stuff, but you know, when we're working with a patient, I don't have a lot of time to be sitting there doing my tablet because we're busy doing patient care, that we put it on that worksheet, so scratch notes, and then make a copy of it at the hospital. We take one back to do my report. So a lot of times the report's getting done later that day, sometimes a week later, right? Yeah, like when I call a guy and say, hey,
Never.
the report looks good, but where's the narrative?
But Jason, too, things you do sometimes record times, you know, so like certain devices we use record times, and yeah, so you can go back.
I will tell you that even though my memory gets bad, if I'm going to court and they're like, we're going to court regarding this case, and even if it was 5 years ago, I go, oh yeah. I can, you know, it might not be every detail, but I know enough, and I also know in the courtroom that if I don't recall, I don't recall. I think, you know, I was always briefed that if you're in a courtroom, it's either yes, no, or I don't recall, and that's it. And as much as I wanna argue with some prosecutor, or, you know, because they try to make you feel stupid, you don't, just, yes, no, I don't recall. Confidentiality, obviously, this breaches of confidentiality, if we're talking to people that weren't actively involved in the patient care or don't need to know, we get in trouble for that. So I use a lot of my previous experiences as case study, but what I'm not doing is telling you where they were, who they were, what location, what town I was in. I'm using it as a learning tool without giving specific protected help, tying it to the person. Always, I'll tell you, if you're ever at a scene and the press is there, they can hear what you're saying even when you're 50 yards away. So those microphones that they got, and I've learned this because I had to sit through, I actually went through training on dealing with press at emergencies, that they'll set up a camera and, you know, the reporter will come up, hey, if you got a minute, I like to talk about stuff, and, you know, yeah, we just gotta do this first. They'll sneak in, well, hey, so what, you know, what's, you know, that thing's recording you, and they'll use that soundbite. So even if Corey and Vanessa, you know, the news is there, and you're kind of off on their edge going, God, did you see that guy's leg hanging off like that? They can hear everything. So emergency scenes, again, here I go with welcome to EMS. It's fun and great. Everyone's got a cell phone. So you go to a public place, and especially if there's alcohol there, I can guarantee you you're being taped. Now, so really be careful about who we talk with. Now, I'm gonna go off script a little bit. If you have someone you can confide in, and especially with mental resiliency, so you saw something bad, I don't ever want you to feel like you can't talk about it to somebody, okay? But you can still talk about how you're feeling without giving patient specifics. Does that make sense? So we never want to divulge information regarding the patient. So the mental resilience thing is kind of the one area, but otherwise, and I'll say this 100 times, we don't talk friends, family, people who weren't on scene about what we saw, what we did. That will get you in trouble. And never, ever, ever post what you're doing on emergency scenes on any form of social media. Ever. And don't take pictures of shit and put it on your personal phone and show other people. Ever. That will get you up to, at minimum, license removed from the state to potentially, for sure, civil, if not criminal. Then you're in trouble. Now, you may see our EMS people take pictures of like an accident scene or with patient permission and injury that we're gonna cover up. Because when we get to the hospital, sometimes a trauma surgeon or the flight medic, you know, they didn't see the car. Later in the course, we're gonna talk about something called mechanism of injury, where you can kind of look at what a car looks like, the outside and the inside, and anticipate potential injury. So there, we may take a photo and we're sharing for the purpose of continuation of patient care. But then that photo what we don't do is then go home and start showing those pictures to people who, and we'll kind of touch on who, well, right here, who can be. So needed in order to continue medical care, so showing that photo to an ER physician, nurse, flight crew member, you know, that's helping continue that medical care. Mandatory reporting as laws apply, and I would have to check, but I think in Wisconsin, any suspicion of abuse needs to be reported, and that can be pediatric up through elderly. Even if you suspect that, hey, something doesn't feel right, report it. I'm sure we've all heard of someone who's had some agency show up to a house, hey, we're following up on a report. You know, I had kids, and sometimes my kids needed their butts whipped. And I got called once because someone saw me abusing my child for swatting her on them. I wasn't, well, no, that's what abusers say. Yes, but when in doubt, we report it. Like, my big fear is my wife falls down the stairs and breaks her arm. And, well, where were you? Well, I was at the top of the stairs. Did you push? Yeah, I mean, they're gonna, you know, follow up on it. But abuse, I think dog bites need to be reported. And who do we report them to? So, as an EMR, you can report it to the ambulance crew. You can report it directly to law enforcement. You can report it directly to the county adult protective or child protective agencies. I know if you guys tell me, hey, when we first got here, it didn't seem right, you know, I would take that information and I'll probably take down your information too. And then I share it usually with the ER staff, and then they share it with, so there's kind of a cascade of events. Required as police as part of a potential criminal. So Vilas County Sheriff's Department calls me and says, hey, I want that patient care report from a car accident. I says, okay, send me a warrant. Which I'm happy to work with law enforcement, or maybe warrant's not the right word. I need some legal court document to release protected health information to law enforcement. So that's all I'm gonna operate. I can't send even patient care reports by email. It has to be encrypted, you know, because I don't know who can grab them. Third-party billing that requires for information, so we contract with a billing company that can see our report. So I didn't send it last time, and I'll probably send it out in a group email. The next kind of couple more quizzes. It's just a basic HIPAA form, and we'll touch on HIPAA is basically what covers protected health information, but that billing company complies to the same protected health that we do. So I have to, all of my staff and anyone who has access to medical records, we have to run them through the Office of Inspector General to make sure they're not on a naughty list. So technically every month, as an ambulance provider, I have to put everybody's names into a database and see if they got in trouble in the last 3 days. Fortunately, I've yet to run into somebody, but if they do get in trouble, well, we have to temporarily suspend their license, or they can't be involved with protected health information. But so I even have to run the 3 people at the billing company. I have to include their names in my check. Or we get a subpoena. You know, you get a subpoena. Fortunately for me, with our medical records, that's a service our billing company provides. So I get a call from a lawyer. Hey, we want, you know, I'm representing John Doe. We want all the medical records from June 1st to December 31st in 2025. I said, okay, here's the number for the billing company, and they'll take care of you. So the billing company takes care of vetting and making sure they're actually a legit, and then they release the records. I don't have to do it. And you'll hear HIPAA, and that's just a federal law that we comply by. And at the EMR level, we don't talk, we don't show pictures. Cobra, really EMTALA is, and for the EMR, it isn't a big thing. This is, kind of dives a lot into, for transporting agencies, but these two came out, and it's really not a problem here, but if you can imagine big cities where, kind of what used to happen is a patient would present to an emergency room, and let's just say it's a homeless person. They know they're not gonna get any reimbursement. They would arrange transfer to a different county hospital, just get them out of here, we're not gonna treat them. So these things basically say, no, every patient that presents on your campus has to have a reasonable medical assessment to identify life-threatening conditions before they get moved to a different facility. And by campus, meaning once I turn on to hospital property, they can't refuse me. There were some exemptions in it where, like, is EMTALA activated? And I'll use Howard Young, for example. So Howard Young has a helicopter landing pad right outside the ER. And if I was coming with a patient and I had no intention of going to the hospital, I'm going right to the helicopter, because I'm going on the hospital campus, is EMTALA activated? Well, they added that exception in that if we are taking the patient to a helipad, it doesn't mean we have to go into the ER first, we can just go direct to the helicopter, right? So at the EMR level, this is more for transport when we're moving to a hospital, just more of an awareness of what it is. And even with that OB divert, so our closest OB facility is Rhineland. Marshfield Medical Center has an OB doc occasionally. They don't have OB services 24/7. I'm sure you all heard in the news, Ironwood shut down their OB. So Rhinelander is our closest OB. And so if we picked up a patient that was, trying to think of an example. Has anyone ever heard of preeclampsia? You know, third trimester. She's got hypertension. She's not in active labor, but she has an OB complication. That we should probably transport that patient direct to an OB facility. That it wouldn't make sense for us to go into Wausau, or I'm sorry, Spirus or Marshfield, Minocqua in this setting. Unless if the patient was, like we were worried about, we can make a justification that I don't think this person would, there's a likelihood this patient would clinically deteriorate in the time it took me to drive to Rhinelander. That's one where we would probably go to our closest facility. Is that, I don't want to dive into too much. And you guys don't have to worry about doing transfers. Yeah, there's just some medical examples of medical ID bracelets. And we'll teach you in patient assessment that we should look for them, you know, as we're doing a head-to-toe exam on somebody, but you almost gotta take them for what it's worth. I mean, I could probably go on Amazon and order a bracelet that looks like that and, you know, give me 200 micrograms of fentanyl, have them put that on. And you guys wouldn't know, is this legal or physicians? So, you know, I look at them. I've never run into one that's false, and I was using it as an extreme example, but, you know, it's usually it'll say like diabetic or hypertension or something. So if someone's unconscious, I can look at it and kind of, if it says diabetic, I know I should probably check their blood sugar. That's what the bracelet's help us with. Tattoos, I carry no weight in tattoos. Now, if I saw that on someone, I'd say, well, we can check their blood sugar. It's not a big deal, but tattoos are not accepted. Occasionally you may run into this, so recognizing death in the field. Now I have a protocol that kind of addresses this, but at what point do we determine the person is dead? First off, at the EMR level, there's not much you have to determine, so when in doubt, start CPR. If you're ever in that situation and the ambulance shows up, takes like 30 seconds and says stop. It's been too long. There's a little bit more diagnostics. So I'll briefly talk about when a person dies. They don't immediately become stiff. We can't use how their body temp as an example. So like today, if somebody went through the ice in the water, and it took 45 minutes to get that person out of the water, so they've been submerged in water for 45 minutes, and they're going to be ice cold to the touch, we are doing full resuscitation on that person. That, you know, the cold water stuff, and even in Wisconsin, we can even be into the summer, and if they're in Presque Isle Lake, it's a cold water drowning. Natural bodies of water, especially in the Northwoods, we consider them. So cold water drownings, if the person were to collapse in a living room, there's no way 45 minutes to survive. But ice, you know, there's a potential there. So we're going to do everything. So we can't, but they're cold to the touch, right? So we can't just say, well, they're cold to the touch, we're done. What we use to determine death is we can do an EKG, so we look for a flat line. Flat line indicates cardiac death. Profound rigor mortis, and what rigor mortis is the stiffening of the body. So upon death, things happen at all your cells, and the muscles will actually contract and hold contracted. This can take, in my experience, anywhere between 15 minutes up to sometimes 4 hours before that starts to occur. There's a lot of things that can vary in there that causes rigor mortis, but if it's not a hypothermia case, so the person's in a home, in a chair, and you go to grab their wrist or neck to look for a pulse and their whole body moves, that is rigor mortis. We don't need to start. Another term that you may hear is anyone ever heard of lividity or rigor mortis? So what that is when the heart stops beating, gravity is going to pull all the blood down to the lower portions of the body. So if I die on my back, within, could be as soon as 10 minutes, you would actually see a line up the center of my body where it's going to be really purple and really white. That's because all the blood, gravity is beginning to pull it down to the lower portions of my body. And if you rolled me over, places like where my butt cheeks are on the floor will be compressed. They'll be, like if I push on my fingernail, they'll be white, but it'll be purple all around it, where that pressure has not allowed the blood to pool in the area. That's lividity. We don't use lividity because in some profound shock states, people can have poor circulation where they can almost have some, what appears to be lividity or blood pooling, but it's actually mild. So we don't teach to look for that. Rigor mortis, injuries not compatible with life. So somebody has, and I have to get a little graphic here, but a decapitation, evisceration of internal organs. So intestines are out, heart, lung. I would say even exposed brain matter. And then up to decomposition. And without getting graphic, you would know decomposition when you see it, when the body begins to break down. Those are times where we can obviously say we're not going to initiate resuscitation. Anything outside of that, if they're still pliable, no rigor mortis, and we don't know, just initiate CPR. So for us, we can show up, do a quick EKG or put 2 stickers on. If it's flatline and there's been no witness to rest, technically we're okay not even starting at that point. We do sometimes, and it's, I was at the store for 30 minutes. We don't know, did they collapse a minute ago or 20 minutes ago? We don't know, but if no rigor mortis is present, we'll initiate resuscitation. Rigor mortis is one of the first areas that a body stiffens in the jaw. So if you're ever on a call and you see me come in, one of the first things I'm doing is I try to work their jaw. And if their jaw don't open, that's rigor mortis. It's been too long. Okay? I didn't mean to get graphic, but those are times that we just don't even start. See, even in here it talks about dependent lividity, and there's been many a case reports where that dependent lividity is actually modeling. So in the state of Wisconsin, any death outside the hospital that is not under hospice care must be investigated by a coroner/medical examiner. I believe Vilas is a medical examiner or coroner. When you guys vote, do you vote on the coroner or the medical examiner?
I've never seen one.
Then it's a medical examiner. So here's the difference between statute, just because I used to do this, that if your county's population exceeds, there's a number there, I can't remember if it's 200, 250, 500,000, but big county, the medical examiner must be a physician. I think there's 2 counties, Dane and Milwaukee, maybe Green Bay. All the other counties in the state can either be a coroner or a medical examiner. Coroners are elected, medical examiners are hired. In Wisconsin, the requirement to be a coroner or medical examiner, for the most part, unless counties make different guidelines, is to be 18, a US citizen, and have a pulse. That's it. You can just run for coroner if you're county resident. You don't need any training. So where the county, where I was a coroner, actually our coroner was elected, and most times they're either retired law enforcement or retired fire and EMS. So some background, but they have to be notified if the death is outside the hospital. In the hospital, you can still have a reportable death, so if they died of anything other than a natural cause, it must be investigated by a coroner medical examiner. So a patient's brought to the ER with a gunshot, the physician can't, they can pronounce death, but they can't certify death. So pronouncing and certifying, like EMS, we can't pronounce somebody dead. Only a coroner, physician, or physician appointee, i.e. hospice nurse, can do that. We can stop resuscitation. So I may put it in my report that we stopped resuscitation at 10:55 in the morning. But we don't pronounce. So pronounce is just that official physician, coroner, medical examiner saying, I can pronounce him dead. To certify a death is to put down what the manner was and what the cause was. That makes sense. So anything that's an unnatural manner, and again, manner of death, it's either natural, accidental, suicide, homicide, or undetermined. That's it. Those are the 5 manners of death, and then causes can be various. Which is why whenever I read statistics about death, that this is the leading cause of death, they get those statistics from death records, and death records are written by coroner medical examiners, and there's a lot of coroner medical examiners with no medical training whatsoever. I used to work for one that was a retired cop, and everybody was a heart attack. There's a lot of other things besides heart attacks. So like anyone want to take a stab at what one of the leading top 3 causes of death in Wisconsin are? What's that?
Accident? Car crash?
No, not car crash.
Alcohol
You
related?
guessed, huh? What's that?
Alcohol related?
Not alcohol related.
Heart disease?
Heart disease is up there. And so when we rule everything out, a lot of times we write complications of atherosclerotic cardiovascular disease, which means it could be stroke. It's actually falls. Falls. Falls among the elderly are a leading cause of death in Wisconsin. Wisconsin's one of the worst states for fall-related deaths. And they are just catching up to reporting them correctly. You take a elderly hip fracture, that can, a lot of times are, so they may die of pneumonia, but they got pneumonia from being immobile. Had they not have had the hip fracture, they probably wouldn't have died of pneumonia. So it's just an underreported cause of death. Crime scenes, you may run in, here it is with crime scenes. First and foremost, we're not going until law enforcement gets there, makes it safe. And I talked about occasionally, if you're on an agency, you get paged out, we want you to stage. And stage means dispatch gives you a location. That's where you report to, and you stay there until they tell you to approach the scene. It's just, we don't have the ability as EMS to, we don't have bulletproof vests, we don't have guns to defend ourselves. You need to let the law enforcement do that. So they will secure the scene, make it tenable, and then they request us to come up. But when we approach a crime scene, there may be, if there is a victim that we need to work on, number one, I can tell you right away if it's a crime scene, probably at some point you're gonna get asked to testify or to give. So those are, you really wanna document them well. You should document every call well. We try to, law enforcement's gonna tell us, we come running up to a door and they may say, no, use that door over there. And they're doing that because we need to document who all, this door may be evidence, that, you know, that door, someone's got evidence that someone did forceful entry. We don't want our stuff going through there, that's part of the crime scene. So if we take clothes off, anything, everything has to stay. We had a homicide case in Rapids that came down to finding the guy's baseball hat. That had the solid evidence that this was a homicide. And that baseball hat initially got wrapped up by, because the guy was in a street, so we took the guy, put him in an ambulance, did a treatment, took him to the hospital, and he ended up dying. The cops took all the clothes that we removed, put them in a bag, and put them in the garbage. Well, they ended up having to go to the dump and dig through and find that hat. So anything, even like kids, babies, things like a diaper. The diaper is huge in investigations. We gotta keep, so anything we take off a potential crime scene, we put it in a bag, give it to law enforcement or a detective or whoever. Even covering bodies, it's always been kind of common practice, somebody dies, they're on the floor, we're not gonna resuscitate, that we want to protect their dignity, cover them up with a blanket. That blanket, if this ends up being a crime scene, we touched it, our DNA is on the blanket, which is now on the victim, and I've seen that in some cases. So a lot of times you're better off, once you determine that the person's dead and we're not doing anything, you just walk back out, leave it alone. Yeah, avoid disturbing potential evidence, you know, I mean, just simple stuff, like we, if there's a hole in a shirt, if we don't have to cut right through that hole, try to cut around it. I can't say never, but I'm pretty confident that this is gonna be pretty minor. Baby safe haven laws doesn't really pertain to you guys, but I don't know if we here comply with that. I'd have to dig into that, but you're starting to see in the news, a lot of fire stations are putting baby boxes, or if someone doesn't want a baby, put it in a box like mail. They are set up that when it's open, it immediately alerts the 911 center, so that they can call fire department or someone to go check the box. That's it. Any questions on legal, ethical stuff?
With duty to respond, you said EMR aren't automatically obligated upon page. When does that change? Does it ever, like as an EMR, once you walk through the door, do you have duty to respond?
EMR's a little bit different because your duty to act is really based upon not if you have a sign-up call, but at some point, where in the legal mind it would hit, but if you commit to responding, so I would say if you answer up, you know, press dial 66, acknowledge, you now have a duty to act, as an example. So, or if you don't have a radio, as soon as you enter into patient care, that duty to act applies. That we can't abandon them unless one of those exemptions that we talked about, things like that. Now, if you're not on an agency, and let's say, I'm just gonna use an example, Ian, let's say he's not on the fire department, he's just, hey, I'm here because I work at the school and I just wanna have extra set of knowledge. So you would be kind of a non-licensed, where you would get a license, but it's not active because you're not associated with an agency. Where it's almost that you become a very well-trained Good Samaritan. It'd be the same culpability if you took a first aid class through the American Red Cross to provide care. Now, he wouldn't be able to carry a lot of the equipment we're gonna learn about in this class, because that has to be, all the equipment has to be approved and is technically comes through a medical director. So you can't carry nasal airways in your personal kit just because you got trained on military class. When I buy medical equipment to put on our ambulance, our medical, they have to have a sheet on file with our medical director signs that I give you permission to sell that equipment to Northwoods EMS. Does that make sense? Where if you carried equipment unlicensed and initiated care like that without being associated with an agency, now you're kind of going outside of your, I guess, scope of practice because you're not credentialed to perform that care. Did that answer the question? I can't remember who asked. Obviously, I'm encouraging everybody to seek out getting on with an agency, because I want to see you guys showing up on calls and helping. We'll take, if I had 10, Steve, has it ever bothered you? Have we ever had too many people on scene?
It bothers me a lot. I like to do everything by myself.
The only time, and I have had an instance where we have kind of a crashing patient. And there's only so much room in the back of an ambulance where I may say, all right, you, and you need to get out. You need the room, and never, if you ever show up, never take that personal. There's too many people in here that I can't work. Which I know it sounds kind of weird, but it can happen when you've got, I'd say the back of an ambulance, 3 is tight, 4 back there, but when you start getting beyond 4 people in the back of an ambulance, that's now you're kind of tipping to where you're impeding. Where there's still things that, hey, can Vanessa, could you go find this guy's wife and write down name, date of birth? You know, that is, even though you're not involved in patient care, that's still, in the overall picture, huge. Just like any firefighters in here? All right, now, is water supply exciting? But are we gonna put the fire out without that water? So every job on an emergency scene is, the person on the nozzle isn't gonna put that fire out if we don't have the water. And we need the water supply people to do it. It's not as glorious and cool, but every component is important. Okay, let's take a last break and I'll jump into documentation. Yeah, it's been 8 o'clock.
Remember to stop your video.
Yeah, do you want to add something?
Video.
Thank you.